Hello, everyone, and thank you for joining us today to discuss how offering total joint replacement surgery can be a significant new business opportunity for your ambulatory surgery center or surgical hospital. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. During today's webinar, we will learn more about the growing market opportunity that exists today for orthopedic surgery in general and total joint replacement surgery in particular, how to build a business case for implementing a total joint program. Our experts will also share best practices for developing an implementation strategy for your own facility. And finally, our experts will share how to ensure your program is successful with performance metrics. So with us today are two subject matter experts from Cardinal Health and New Health who will help us better understand this opportunity and, more importantly, how to take advantage of it. So with that, I'll kick things off by introducing our two presenters today. First, we have Sheila Konecki, who has been the Vice President of Supply Chain for New Health in Leawood, Kansas City since April of 2014. She is responsible for all supply chain functions for 52 ASCs and specialty hospitals owned and managed by New Health. She is also responsible for the development of new facilities, ensuring all the equipment and supplies are available when a new facility is opened. Driving waste out of the supply chain has been a top priority for Sheila. Using lean methodology, she focuses on best practice processes to improve the efficiency of contracting, procuring, and stocking of medical supplies throughout the facilities. Sheila has over 30 years experience in healthcare supply chain, with the majority of her experience in large trauma centers. We're also pleased to be joined by Marvella Thomas, who has 36 years of clinical experience in healthcare institutions. Much of her experience as a clinical leader includes management roles in surgical services, central sterile and administrative services at acute and ambulatory facilities. In her clinical management roles, she was responsible for department planning, organizational effectiveness, and staff development. She was also accountable for driving results that included fiscal and quality improvement activities. Major emphasis was placed on supply chain efficiency and inventory management. She's also managed through 2 new facility construction projects. Currently, as a senior consultant for Cardinal Health, she leads a team that conducts operational assessments focused on product utilization, process improvement, supply chain management, and space utilization. Thank you so much for being here today, Sheila and Marvella. Let's take a moment to learn a little bit more about each of your companies. Marvella, we'll start with you.
Absolutely, and thanks, Emma, for that introduction. So with more than 40 years of experience, Cardinal Health is a recognized leader with a top ranking for transforming the healthcare supply chain to meet new challenges around costs, revenues, and outcomes. In particular, Cardinal Health is a leading supply distributor for surgical hospitals and ambulatory surgery centers. But in addition to products, they also provide services and solutions like our clinical consultants. Our team of perioperative ambulatory nurses average more than 20 years of OR and supply chain experience, and they work daily with ambulatory facilities to improve efficiencies and maximize your revenues. Our clinical consultants have walked in your shoes and have seen the challenges you face every day. More importantly, while on site, we can be a fresh pair of eyes to help you meet these challenges.
Thanks so much, Marvella, for sharing a little bit more about Cardinal Health. Now let's turn to Sheila to learn more about New Health.
Thank you, Emma. New Health is one of 5 platforms of its parent company, Value Health. We help providers transition to value-based surgical care through our vast platform, in addition to owning and managing our own network and surgery centers and specialty surgical hospitals. New Health has over 3,000 physician partner relationships and more than 30 health system partners. Currently, we own and manage 60 ASCs, 10 surgical hospitals, 9 BASS ACE-certified surgery centers, and 6 hyperspecialty surgery centers. We're in 28 states across the country and are expanding exponentially.
Excellent. Thanks so much, Sheila. So now let's go ahead and dive in and turn our attention to orthopedics by reviewing the current landscape. Marvella, what do the next 5 years look like for orthopedics and total joints?
Well, the growth projections continue to expand as our population ages and our technologies advance. Now, not all patients will be candidates to migrate to the ambulatory space, but the growth will still be significant. Many procedures and more procedures are now shifting from inpatient to outpatient, and joint replacements are leading the way by a wide margin. The joints predicted are to rise in the ambulatory space by 96% over the next 5 years, while procedures in the acute space will continue to decline. We feel like growth is being driven by the 3 Ps that are involved. And those 3 Ps are your patients, your providers or your payers, and your physicians. So when we talk about patients, the need for total joints has increased as our baby boomers age. The benefits of this aging population, their age and limited mobility certainly makes ASCs much easier to navigate. There's better parking. You can park close to the door, and you don't need a map to figure out where you need to go once you get inside the building. These centers are much more accessible than the typical acute space. There's a less complex environment with a lower chance of exposure to infectious disease. Many times, the patient's out-of-pocket costs are also lower. And I also feel like there's increased inclusion of your family and caregivers because of the smaller space and the less complexity. Now, when we talk about payers are actually steering their patients to the ASC setting because of the reduced cost and positive outcomes. Some payers require a pre-authorization process for total joints that can be performed in the ambulatory space to make sure that these appropriate cases are funneled there. And then there are your physicians. They're really no different than the patients. The ASC space is easier to navigate and easier to access, and sometimes their parking is better as well. They can do all of their surgeries in one location, both their total joints and their sports medicine procedures on the same day. Your center actually becomes a one-stop shop, which with much less complexity and a calmer environment.
There's no doubt that there is a significant opportunity as total joint shifts to the outpatient setting. So thanks so much, Marvella, for laying that out. And Sheila, perhaps you can share next what the opportunity means for ASCs.
Yes, as Marvella stated, there's a potential to increase our outpatient procedures by 25% over the next 5 years. The majority of the volume is coming from total joints. Some of that total joint volume is the result of CMS approving to cover the cost of total knees in the outpatient setting. And because we are all much more active, even in later life, more and more people are great candidates for their surgery to be performed in the outpatient setting. The insurance companies prefer and benefit when a procedure is performed in the ambulatory setting. Overhead is lower, reducing the cost, and in turn, the claim is lower, providing an opportunity for larger margins and top revenue for both the payer and the center. It's important not to overlook this physician satisfaction. Providing the surgeons with one location to perform all of their cases reduces the need for them to go from the surgery center back to the hospital and back to the surgery center again. If they are also investors, they will also have an increased revenue for their ownership. The most important benefit to adding total joint replacement to your surgery center is the increase in patient satisfaction. Surgery centers do not have all of the infectious diseases that large hospitals have, reducing the risk of infections. Surgery centers are usually closer, friendlier, they have a more home environment, and they cost less for the patient.
So there's a clear opportunity and benefit for ASCs to add total joints. So thanks so much, Sheila, for laying that out for us. Now let's learn about the steps an ASC would need to take to implement total joints in their facility. Sheila, how do you get started with adding total joints to a facility?
There's a lot of things that you need to consider. We've outlined the key steps here in the slide to implementing those total joints, and we can discuss each one in more detail, but I wanted you just to see all of the things that you need to look at right here.
Excellent, and we will dive through these steps as we go through the presentation today, so thank you so much, Sheila. Let's start with you for that first step. Why should an ASC build a business case before deciding to implement total joints?
Every facility is different, so you can't really have a cookie cutter process that will work from one facility to the next facility. So you need to know what your own market is, what opportunities are available in that market, and if it will be profitable for your center. When you assess your market opportunities, there are databases out there that you can have access to that will show you what the steerage is, how many of the population in your area are going outside or to another town to receive these services, and you can get that information. It's available sometimes through a fee. Once you find out the number of patients that are leaving your market to get care, that is your where you need to look to drive that steerage back to the market that you are in. You need to look at your location and the ease it is for those patients. Are you centrally located within that demographic? You also need to, and it's very important, that you look at the regulations that are in your township, your state, as well as federally. Do you need a certificate of need? Are there special state rules or regulations around whether or not you can do a total joint in an ASC, even though CMS has said it's true? You have to obtain or know what you need to obtain to have permission from the government as to what you can and cannot do in your facility. You need to look at the return on investment or a pro forma for each one of your projects. Find out how many physicians are coming and the number of cases that they're committing to your facility. When we do this here at New Health, we always take that number and take 25% off, because there will be those patients that will just not be a good fit for your facility. And then you need to estimate the reimbursement for all of your cases and decide if that's a good investment, because you will have some upfront costs.
Thanks, Sheila. It is certainly important to understand your specific situation and if it would be beneficial to add total joints. Marvella, once you've done your assessment and you have the business case for adding total joints, who do you need to get buy-in from and how do you get it?
Well, buy-in from your physicians and staff is extremely critical. It's important to meet the physician expectations. Your physicians need to be comfortable with the patient going home a few hours after surgery, and they also need to be assured that plans have been implemented for a smooth and safe transition for their recovery at home. We have to understand that this is a huge shift in practice for many of our physicians, and we have to be supportive. Sometimes showing physicians data on positive outcomes can increase their comfort level. And don't forget to include anesthesia in these discussions. Your entire team at the facility needs to be focused on the process. Everyone needs to be on board for a smooth implementation. And what about your other physicians in other specialties at your facility? Will this affect their block schedule time or their availability to perform their procedures? They need to feel confident that it will be business as usual for them and their patients. When you're trying to get buy-in from the staff, your pre- and post-op staff are critical in managing the expectations of your patients and families. They have to have comfort and a positive attitude when dealing with these process changes. You can't forget your OR staff. Are they comfortable scrubbing and circulating on total joint procedures? Some of this will depend on the practice and the specialties they've been working in the past. So for example, a scrub tech who's primarily done eyes for the last couple of years is probably not going to be comfortable doing a total joint procedure. And the same will go for the RN in the room. They need to be comfortable with the different tables, equipment, positioning devices that are going to be needed for these procedures. You definitely have to provide your staff with education and support so they can function. Your SPD tech is probably also wondering how they're going to get all of this done in addition to the workload they already have. Will you need to bring in extra help on total joint days to help manage the flow of instruments? Everyone needs to be included in the planning process and need to feel comfortable with these changes.
Thanks for sharing how to prepare your staff for total joints, Marvella. Perhaps you could walk us through how to prepare your facility for total joints as well.
The first thing to do is to get your team together and walk through the facility to visualize what your case and patient throughput is going to look like. You need to determine if any physical modifications will need to be made to accommodate these procedures. And if so, these can be costly and time-consuming. You have to look at the size of your rooms. Are they really safe to accommodate the equipment needed, such as specialty tables and C-arms? Or will you have to move excess equipment and clutter from your existing rooms that are being stored in there? And when we talk about storage, you're also going to have to review your storage capacity, not just for the additional supplies like custom packs and disposables, but what about the additional equipment you may need? Where are you going to store those items? When we talk about equipment, you have to review what you already have. And is it in good working order? What tables do you have? Do you have a table, a special table for anterior hips, or are you going to need to purchase one? Do you have hoods, and where are you going to store them? You need to make sure that you have the basic instruments that are needed for reconstructive orthopedic procedures. These can vary greatly from the instrumentation you're using now in sports medicine procedures. Your implant vendor may provide the specific implant instrumentation that's needed, but those basic instruments are going to be up to you. You have to look at your carts and the stretcher beds, the pads on the beds. Your patients are going to be laying on these stretchers for a longer period of time, and you need to make sure they're comfortable so you can maintain your patient satisfaction levels. Some facilities are actually providing cubicle walls to replace privacy curtains that give patients and their families a quieter and more comfortable environment for recovery. Do you have SCD pumps? Protocols recommend SCD pumps for these procedures. And assessing the SPD department is extremely critical. Overlooking this area is a common pitfall that we see. Do you have a washer sterilizer in your facility? Because not all facilities do. And are your sterilizers large enough to accommodate the number and size of instrument trays that are going to be needed for these procedures? And what impact does this have on your regular daily schedule? The SPD is critical, and it's actually your first line of defense in infection prevention. So you must have adequate capacity to handle the caseload.
Thanks so much, Marvella. That was a great look into preparing your facility. Sheila, as a next step, can you walk us through the next steps in terms of determining equipment and supply needs?
Yes. The first thing that I always try to do is have key conversations with your stakeholders. It's critical to understand what your immediate needs are And the surgeons frequently know which manufacturer, which rep they use, but they're not really great on the detail on which particular product. So I always try to go to their first assist because they will have all those details that the surgeon won't. And then as you've gone through and assessed your facility, once you complete that list, you need to compare that to what your needs are going to be. And a good place to find that list of what you need is off of the physician's preference cards. So I would compare what is on the preference cards for those surgeons when they do their total joint procedures and compare it to what you have and come up with a gap analysis. And like Marvella said, you need to look at the shape that your current equipment is in. Do you have the right OR table or the right accessories for the OR table so that the patient placement is in the right place? Or do you need to go out and buy a specialty table? Sometimes you can't do an anterior hip on a regular table. You need a specialty table, and those are expensive. You need to evaluate your instrumentation. So, for example, a hammer that a surgeon's been using on small bones will not work when he's working on a knee or a hip. So you have to get heavier hammer in. These are just some of the few things that we look at. We also have to look at what cement mixer are you going to use. Some of them use nitrogen, and if you don't have nitrogen piped into your ORs, you have to make room for a tank, and that's one more piece of equipment you're bringing into the OR. And the list can go on and on and on. And it's important that you don't forget to reach out to your vendors. They will be able to help you with the additional supplies that you might need. One of the things that we've done with Cardinal is we're starting to standardize on a total joint pack so that we can use the same pack over and over, and that reduces the time that it takes the nurses or scrub techs to pull for their cases in advance. And once you set up some of those standards, it makes it a lot easier and a lot more efficient for the nursing staff.
I think that is a great segue into our next step, which is contracting. Sheila, let's stick with you to walk us through this one.
There's several contracts that you need to take into consideration and you need to review. The first one that I would look at is your payer contracts. You may have a contract with the major insurance companies or major payers in that market, but you need to make sure that your total joints are included on those payer contracts. And if they are included, does that reimbursement cost include the price of the implant, or do you have a carve-out for the implant, which I hope you have a carve-out. Once you know what your payer contracts will allow, you can then reach out to your implant vendors to negotiate the cost of your implants. I can go on for days and days and days about negotiating implant pricing. I've been doing it for over 20 years, and it's never gotten easier. You have to remember that that sales rep for the implant company has been developing a relationship with the surgeon for years, and you have to get in between that relationship. I always try to have a conversation with the surgeon before I ever talk to the implant vendors. And I ask them, let me handle the business side and you handle the clinical side. And that way there's not a lot of back and forth and the reps aren't running up and saying, no, I can't feed my kids because you won't pay me $5,000 for a total knee. So that's always been helpful if you can get in front of those reps right away. Another contract that a lot of people won't think about or haven't thought about is contracting with a home health agency. You may not use it on all of your patients, but when you do need to have one, it's good to have it all established up front, and then you're not scrambling on the back end. And don't forget about physical therapy. It's vital that your patients get moving right away, but they need to be moving in the correct way. We don't want any DVTs, but we also want to make sure that they have the best outcomes when they have their total joint done in your facility. And that will go a long way to improve your patient satisfaction.
Sheila, that is great advice on equipment and contracting. Thank you. The next step is developing a care plan. Marvella, can you walk us through this one?
Absolutely. I'm a nurse, and we always have to have a patient care plan. And in this situation, a nurse navigator or a case manager is definitely recommended, but most ambulatory facilities don't have one. So is there a clinician in your facility that has the skills and the desire for this type of position? Careful patient selection, education, and planning is key to successful outcomes. Your nurse navigator starts the planning process by evaluating the patient's home environment and their capacity for understanding and following your protocols. Does the patient live in a multi-level home? Do they have easy access to a bathroom or the bedroom? And does the patient have the supportive caregiver at home, or are they going to need help from a home health agency, as Sheila mentioned? When you're developing your pre-op plan, there's additional consideration for these types of patients. You'll need to provide extensive pre- and post-op education because these patients are responsible for their own care when they return home. Determine who will provide that education, and if the patient's going to need access to any supplies, where are they going to access those supplies? For example, you may want your patients to do an at-home skin preparation prior to surgery to reduce bacterial flora on the skin and reduce the risk of infection. Your protocol may also include nutritional supplements prior to surgery because they've shown to hasten a speedy recovery. So where will these supplies come from? Do they get them from the physician's office, from your center, from a home health agency, or do they have to order them online or at the local pharmacy? And after surgery, what are the plans for your pain management protocol? Pain management is important not only to prevent addiction, but also to keep the patients comfortable in moving. And are there other pieces of durable medical equipment that might be needed in the home after surgery, such as an SCD pump, walkers, or canes? All clinical needs are driven by your care plan and your processes. You have to have recovery milestones so you can effectively evaluate your outcomes. Determine ahead of time what quality indicators, milestones, and outcomes you're going to be using at your facility. Again, patient and caregiver education and expectations are key elements of your program, and I can't stress this enough. Some of the things that seem simple and self-explanatory to us may not be for the patient. A good example of this is a patient that shows up at the ER 1 to 2 days post-op with a blue foot thinking they have poor circulation. And actually what happened was the patient was prepped with a tinted prep solution, and no one at the center told them they would have a blue foot until the solution wore off. So education and expectations are going to be extremely, extremely important.
Thanks so much, Marvella. And it seems like we've really worked through all of the logistics of implementing total joints. So Sheila, what's next?
Developing your market, I believe, should be your next place to go. There are several ways you can do that. You can contact your private payers and negotiate agreement, maybe reducing or eliminating the patient's deductible if they steer the patients to your facility. Make sure you're on that payer's preferred facility list. Payer relations are, you need to improve those to make sure that you are the best or their first choice when a patient needs to have a total joint replacement done and they're looking for a facility. Just eliminating that risk of patients going to the ER after or any readmissions. Typically in our facilities, they're significantly lower, and that enables us to get better rates by the payer because the payers are comfortable with very little or no readmissions. And then if there's a large employer in your market, I would say go out to them and maybe negotiate something on your own without the insurance company. Many of them are self-insured, and if they're able to get a better rate going direct to you than going through their insurance company, they're going to jump on that. You can work with your current physicians and find out if they know of any orthopedic surgeons that are really busy and might be interested in increasing their volume by coming to the surgery center. The most important thing you need to do is you need to tell your story. You need to really say how great your facility is, how calm it is, how convenient it is for the patients. And you may need to make sure that the community knows they can come to your facility, have these total joint procedures done, and that they're safe.
Excellent. That is great advice on how to better drive patients to your ASC. So thank you so much, Sheila. Marvella, we'll turn to you next. What should ASCs know about accreditation requirements before they add total joints?
Well, we're all aware of those basic requirements that we have for, keeping our centers clean, clutter-free, supplies up off the floor, fluids on the bottom shelf and not over sterile supplies, and supplies under your sprinkler systems. But we're talking about the importance of researching and understanding regulatory requirements in your particular geographic location. So in addition to the regulations from AAA, HC, JCO, and CMS, there may also be regulations posted by state and local governments in your area that you need to be aware of. Make sure you're compliant with these regulations as well. And also your payers may have specific requirements that you'll also have to be aware of. AMI recommendations for sterilization are also extremely important. Make sure that your SPD department has the resources and the processes to meet these standards. And make sure that your vendors know the importance and follow those standards as well. Do your trays arrive in time for appropriate processing and sterilization? Just because the vendor brings them in and says they're clean doesn't mean they don't have to be washed before they're sterilized. And also make sure that the trays are within the 25-pound weight limit for sterilization. When we talk about AMI recommendations, it's also important to protect your patients and staff from harmful body fluids. These procedures can be pretty fluid intense at times and would require AMI Level 4 personal protective equipment and drapes. So that's something else to work through with your vendors to make sure that you're providing the right protection for your patients and staff. These are all elements of a successful program. But New Health also has a program to help facilities meet and exceed all of these requirements.
Excellent. And Sheila, we'll ask you to dive into a little bit deeper on there. New Health does have a program to help with accreditation. Is that right?
Yes. New Health has developed an ACE program. We worked on this all last year. It stands for Ambulatory Centers of Excellence. And as we went out, we reviewed all of the AAAHC Total Joint Certification, Blue Cross Blue Shield, Blues Distinction, Joint Commissions, Joint Center of Excellence. We lined up all of their criteria and a few more. And we determined and looked at things side by side across all of them. Then we raised the bar a little bit more and just to make sure that we are covering everything. And we developed a program that's not only for our facilities, but it can be put into any other center. We've have the implementation plan. We go in and do a gap analysis, and we make sure that certain protocols are followed to ensure that anybody can come to your facility that meet those criteria, and they will have a safe and successful procedure done. We actually don't even use wheelchairs when we discharge our patients. We have them walk, and that's their first 50 steps post-op. Not their first 50, but it's added into it. We do have that ability to kind of put it into any other facility and then take a step back. We monitor certain things to make sure that your infection rates are none to zero or very, very low. We monitor your patient satisfaction and your physician satisfaction for these procedures only.
Thanks, Sheila. So that takes us to our last step, measuring your performance with metrics and tools. Can you tell us about the metrics and tools you use?
The first thing that we look at, and we're looking at this, it feels like every day, but I'm sure it's more like weekly, is your case costing. If you don't understand and measure something, then it can get out of control really quickly. And especially with sales reps in the OR, creep comes in really quick. So we monitor our case costing down to the salaries of the people that are in the room to make sure that every procedure that we're doing, that we're profitable. There will be times when it's necessary to do a procedure that does not make a whole lot of money, or maybe you lose a little bit of money on, but that's what's best for the patient. We also monitor the infection rates weekly, looking for any trends. Thankfully, New Health, we've had very, very little infections. As a matter of fact, in 2019, we performed more than 1,800 total joint surgeries in our ASCs. We did have 2 infections, one in a uni knee and one in a total hip. So for 2020, our goal is to reduce that infection rate by 2. We use a couple of major benchmarking repositories. We use HCAP scores and then SPH analytics, primarily because we do have hospitals and ASCs. One is geared more towards an ASC and one is geared more towards a hospital. So that's why we're using the 2. And as you know, if you're familiar with these scoring mechanisms, most of the country, they're in the 90s already. So it's hard to be in that very top quartile, and maybe just half of a percentage point will move you into that quartile. But we have worked really hard with putting in protocols to ensure that you get to that top quartile as much as possible. And then we continue to monitor those scores. And if we start seeing creep or something, then we'll go ahead and come in and continually improve upon our processes and our protocols to make sure everything is on the up and up.
Excellent. Well, thank you so much, Sheila, for concluding today's presentation, talking about the metrics and the tools that you're using. And with that, that ends today's formal presentation, but we still do have time for Q&A today. So we thank you for your attention. And before we jump to the Q&A section, please do take a moment to complete the survey we've given each of you. Your feedback is invaluable in helping us continually improve the value you receive from discussions such as this one. So as I mentioned, we will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. And it looks like we've already had a great number of questions that have come in. We'll start with this audience question first. You talked about this a little bit, both Sheila and Marvella, but what can vendors do to help with the implementation process?
Well, I think it's important that you understand what resources you have with your vendors. Do they have clinical consultants that can help? Do they have an implementation team? Do they work with other folks, other companies that are involved in total joint procedures? So utilizing those resources, where that's going to be extremely important also is when you're developing the custom pack that Sheila mentioned, for your procedures. So knowing what vendor resources are available, and you just have to ask, do you have consultants? Do you have an implementation team? Do you have a process that I can follow for implementing these procedures?
And we also have partnered with, some people may find it unusual, but we have a partner on our sterilizers that specialize on throughput. So we will send them what our projected volumes are and the equipment that we have in that space, and they'll come back and tell us how many man hours does it take to get all of those trays through the equipment we currently have. So that'll give us an indication on whether or not we need to upgrade to larger chambers or something like that. So it's important not only to think of your distributors and your implant reps, but also look at some of your equipment reps too.
That is great advice. Thank you, Sheila and Marvella. The next question that we have here is the audience member is asking, are robotic joint procedures practical in an ASC?
Well, robotics add a lot of expense, and especially with some of the robotics out there, you have to buy special packs or additional supplies just for that robot. It does add costs that is not reimbursed through this, your payers. But I will admit, we do have robots in a couple of our ASCs. And what it has done is if the surgeon is really, if he's very familiar with the equipment and he can increase his speed, then that's allowed us to increase our throughput and add another case on the end of the day. I would not really recommend it unless that surgeon is familiar enough with the case and he's been using the robot in a hospital setting.
Yeah, that's a great point, Sheila, because if they're not familiar with the equipment, it can add a considerable amount of time to your daily schedule, and it also adds a lot in disposable costs. So it's kind of a balance in knowing what your ROI is going to be.
Yeah, and plan on spending at least $1 million, if not $1.5 million for a robot. Unless, well, I shouldn't say that. There are some robots out there that you probably get for $500,000, but I don't have $500,000, so that'd be a tough sell for me.
That was super helpful in weighing kind of the cost and output from robotics in your ASC, so thank you for that. The next question that we have here is what considerations should be made for MRSA pre-surgical screening?
Well, I think that's where your nurse navigator comes into play. Patients, they're just like any other patient in an ambulatory surgery center. There has to be low comorbidity. They basically have to be healthy ambulatory patients. So making sure that your screening includes a good, physical examination, a review of, the patient's cognitive abilities. Are they able to follow instructions, and do they have the resources at home to recover? Patient selection is extremely important, and it's going to start with that screening process.
I would agree.
Great. Thanks so much, Marvella. The next question that we have here from our audience is asking about bundles. So perhaps, Sheila and Marvella, you can share your thoughts on recommending trying to do bundles in an ASC.
We actually do bundles quite a bit, and we're actually trying to get more bundles in the ASC setting. One of the unique things that we're doing with our bundles is we're including everything from the time that it's determined in the physician's office that a total replacement is needed. So all of the pre-op, the surgery, the post-op, anesthesia, PT, a home health, and we're also putting a warranty on it for 6 months. So we really are partnering with payers on bundles, and we have quite a few already in place.
Excellent. Thank you. And Marvella, I'm going to direct this next question to you. You talked a little bit in a previous question about, selecting patients and how important that is for the pre-surgical screening. So how do you ensure doctors are selecting patients who are safe to have surgery in an ASC, especially when we think about Medicare age patients?
Well, I think that your physicians are going to be sensitive to that because they absolutely want good outcomes as well. But there again, I can't stress enough having a nurse navigator that really works with the physician in his office. You have to have screening criteria that's more than just, the age and weight of the patient. What other diseases do they have? What medications are they on? Do they have any other special needs? But again, I think physicians are sensitive to this issue because, they have to report their outcomes as well. And working together with the nurse navigator and making sure you have good pre-admission criteria is definitely going to be an improvement to the process.
I know that at New Health, we've set protocols for the physician to follow, and they can have a comorbidity, but maybe not more than 3. And I think in some cases it's patient by patient. The physician really has to know whether or not that patient will be able to, whether or not they'll be mentally able to handle having a big surgery done, total joint replacement, and then getting up and going home.
Walking home, yeah.
Not walking, but walking to their car.
Excellent. Thanks so much for going into some more detail on your experience with the patient selection process. The next question that we have here is in reference to the care plan slide that you guys presented on. So what is your recommendation for pain control after leaving the facility, an ASC or a surgical hospital? Are there specific devices that should be provided to reduce dependency on opioids, or any other suggestions you would have there in terms of pain control after leaving the surgery after an ASC?
There are medications that can be given before the patient leaves the surgery center by anesthesia that can help manage the pain post-op. These medications tend to be expensive, so they're going to add some cost, but the bottom line is the patient's probably going to recover faster and have less chance of dependency on opioids. I think, you have to monitor your opioid prescriptions that patients are going home with. They should be up and mobile, so they're not going to need a prescription of 90. So I think, making sure that you also have criteria for how you're going to manage that. Things like TENS units can sometimes help with pain management, the electrical stimulation. Just motion, the physical therapy and getting the joint back where it needs to be is going to go a long way in reducing pain. So keeping the patient mobile is going to help. And again, there are medications that are appropriate for use without the use of a lot of opioids.
Great. Thanks so much, Marabella, for that. And then we've had a number of great questions come in. As a reminder for the attendees that we do have on the line, you can submit any questions you have by typing them into the Q&A box that you see on your webinar console. Sheila, we're going to direct this next question to you. It's about the ACE program that you mentioned that New Health offers. So perhaps you can clarify if the ACE program, you have one for ortho certification to ASCs not in your network.
We do provide that to facilities not in our network. We call that VAS, value added as a service or something like that. I'm sorry, I'm messing that up totally. But we do provide that for people. And so if you're interested, please feel free to reach out to me and I'll direct you to the appropriate person. I'm not the one that does it, but I know who does.
Great. Thanks so much for providing that insight and clarification there. Next question we have here from the audience is, how soon should I start planning? So we talked about the roadmap, and perhaps you guys can add some more clarity into how soon someone should start planning and what the timeline looks like for the entire process.
I would start planning right away. For me, I would feel more comfortable going to an ASC to have a total joint done than I would going to a large hospital, because I have contracted a hospital-acquired infection, and I am not seeing, or I have not seen proof of those type of infections happening in a well-run ASC. So I would start planning now. It could take up to about 6 months. Sometimes you can do it sooner. It really depends on your equipment. I know some sterilizers right now, if you have to buy sterilizers, there's 30 weeks out is the lead time on those sterilizers. So I would start now, and as soon as you can get all the equipment in, probably in about 6 months, you can be doing total joints.
And that timeline is going to be increased if you do have to do any physical modifications to your center. You know, if there's any construction that needed, or like Sheila mentioned, if you need to install a washer sterilizer or a larger sterilizer, then that's probably the construction is not only going to increase your cost, it's going to increase your timeline as well.
And that's where your biggest expense will be, and where the most of your time will be spent.
Excellent. Thank you both for providing more details around the timeline there. The next question that we have here is, so in the roadmap that we discussed today, we talked specifically about total joints, but would this roadmap work for adding on other new procedures as well?
You know, we actually use this similar roadmap. The only thing that's different is the equipment that you're looking for and the supplies that you're looking at for all of our procedures. Whenever we're adding a new procedure to any one of our facilities, whether it's GI, spine, bariatrics, we use a roadmap very similar to this. The only difference is the equipment you're looking at and the supplies that you're looking at.
Yeah, I would agree absolutely that this roadmap can be used for any specialty you're looking to add, whether it's robotics or any other spine procedures, that type of thing. It's all about the planning and doing that first initial assessment, not just of you know, the area that you're in, the physicians you have, but looking at your facility and determining, you know, what's your ROI going to be on the investment that you're going to have to bring on a new facility or a new specialty. But, yep, the same plan will work for any specialty.
Excellent. Great. Well, thank you both. And we have a few more questions that have come in, so we'll move to the next one. This audience member asks, how do I know what new supplies I might need for total joints?
The first place that I look is those preference cards. They are so important because on that preference card, if I'm going to put a little tag in here, as long as the preference card is accurate, usually what we do is we go to the physician and say, where are you doing your procedures, where today? And then they get copies of their preference cards and send those to us. I go through that preference card. I'm looking at what he's using for scrub, what equipment he's using, what patient positioners. It should all be on that preference card. If it's not on that preference card, then I'm on the phone to his first assist or to the office to find out exactly what he's using during those cases. So that preference card will tell you everything that you need to know, down to the size of the surgeon gloves.
Yeah, that's definitely where to start. And a lot of times I like to talk with the techs, the scrub techs that are familiar with those procedures, and have them review the preference card with me to see, okay, is there something missing here? Sometimes there's obvious things. Sheila mentioned the card being accurate. But, you know, having a tech, someone else look over the card with me, but absolutely that preference card is your roadmap for all of the supplies and equipment that you're going to need.
And a good thing with talking with the tech also, Marvella, that you reminded me of, I also have the instrument trays there, and I asked that tech, how often is the surgeon using all these instrumentation? Because a lot of times they'll only use 30 or 40% of all the instruments that are in that tray, and those instruments can get expensive. So if you can pare that down to what he's using all the time, and maybe just have once in a while items that he uses, put those in a stereo and have them on the back table, but not opened. So they're available, but you're not re-sterilizing things for no reason.
Yeah, that's a great point. Yep.
Excellent point. It sounds like remembering the importance of preference cards is key here. So with that, it looks like we do have time for just one more question. And so I'll ask this question and feel free to respond and then give any final thoughts from our webinar today. So the last question that we have here is, are there any additional considerations for acute facilities looking to move and shift towards total joints?
Well, I think the most important thing is that they also shift their philosophy to the non-acute setting and non-acute processes. Where I've seen facilities struggle is when they're trying to use an acute model in a non-acute setting, and it definitely will raise their costs and reduce their revenues. So, you know, it's possible to move those procedures, but make sure that you're also shifting your priorities.
One thing that we've experienced here at New Health is we have facilities, acute facilities, reaching out to us because they don't have any more volume available in their ORs. They're having to turn away cases that because they're doing a lot of things that could be done in an ASC setting, taking up that OR time. So if we can move those surgical cases out of their acute care setting that do not need to be there, that can be moved to an ASC, that frees up their OR time for those more complicated cases, maybe some open heart and some of those type of cases. And we put the total joints and all of that into the ASC setting for them. And that's how we partner with our health providers also.
Excellent. Awesome. Well, I think that's a great note to end on today. So I did want to thank Sheila and Marvella for their excellent presentation and to Cardinal Health for sponsoring today's webinar. We hope you enjoy the rest of your day, and we look forward to having you join us for future programs.